How do clinicians do solution-focused brief therapy in practical terms? Let's move beyond theory and look at what this really looks like in real life in practice settings. So I'm going to walk you through what it really means to be solution-focused and brief, go through several specific tools that you can use with clients, and then I'll also be offering some case considerations and critiques and just some tips from me to you. Before we get started on any of this, though, I want you to keep in mind my little acronym, EAP in every terminal, which is supposed to be a memory tool to remember the steps of the helping process. Engage, assess, plan, intervene, evaluate, and terminate. Basically, first things first. Even though as social workers or other mental health professionals, we want to help people. We want to learn about all these tools for interventions. That's great. But before we can get to that stage, we need to engage the client with exploring their issues, building rapport, validating them, showing empathy, all of those different micro skills, and then making a more formalized, assessment as well. This could be a biopsychosocial assessment or an assessment related to a specific mental health concern, then setting goals, making plans, a treatment plan, before you would really use any of these specific intervention techniques. So once we have got our clients feeling comfortable, we have that strong therapeutic alliance, got a trauma-informed space and approach, you've done a proper assessment, etc., etc. Now what? So if you are using a solution-focused approach or modality, this is helping people essentially to build change in their life in the shortest amount of time possible. So it's kind of looking at solutions and let's get them as quickly as we can. Sounds pretty good, right? People have problems, they want them to go away and fast. So it's certainly appealing on that level. The two main ways that this happens is to help our clients to envision what exactly their preferred future looks like, and also leveraging instances of success or exceptions to the problem, both in the past and the present, to build our skills in making that preferred future happen, essentially. It really centers around the idea that we want to move towards solution talk instead of problem talk, and that we're focusing more on the future than on the past. So a lot of stereotypical conceptions of psychotherapy involves a lot of discussing of problems and analyzing roots in our past, right? Our inner child or early childhood experiences or past trauma. And I'm not trying to poo-poo on any of that. I think there can be a time and place for working through having that safe space to share and venting and having that insight. But in this approach, we are going to be talking more about solutions and the future. So here's an example of what that might look like. These are problem-focused questions on the left and solution-focused questions on the right. So a problem might include what happened to you versus what's your first step going to be in starting the healing process, or how are you going to cope with what happened to you? Why are you depressed versus what makes you happy? Talk about your limitations, like, for example, if someone has an accident that left them with some sort of disability, focusing instead on what can you still do? Or problems of other people. How should you respond when your toddler throws a tantrum versus what helps your toddler to be able to get out the door without an incident? And in the case of maybe an eating disorder, say, how is food restriction impacting your health, right? What are the problems, bad consequences associated with this versus what's going to motivate you to eat healthy? So clients often come to us with a problem to solve, of course, and we have to realize that implicit in that is that they also, by definition, are seeking a solution to that problem. And so we are focusing on that, being more proactive instead of reactive. And this reminds me of just a side tip that I'm going to give you about action-oriented goals. When we think about goal setting, whether in therapy or in our own personal and professional lives, you should use the same principles of looking towards a positive or something that exists rather than something that you want to avoid. It's easier for our brain to envision doing something than not doing something, or the absence. So for example, this little agility dog here in the photo might say, I want to be able to clear the red pole, as opposed to, I want to avoid knocking down the red pole, right? I want to go the whole race without knocking any poles down is more problem-oriented, whereas I want to go the whole race clearing all the poles is more solution-oriented. Another note of caution here is that when we are trying to focus on solutions, we are focusing on the positive, we can seem kind of uncaring or impatient. And so this, again, is why I started with remembering those micro skills, because we need to still show empathy. We need to still have active listening. And it really can take some skill and experience to find that balance where you're really listening and making them feel heard and understanding the problem yourself, but also gently moving them away from that problem talk and towards the solution talk in a way that's still affirming and not rushing them. So I'll talk about this a little bit more because I have a specific analogy that I use for this. But first, I'm going to give another example of problem versus solution focused. If you've seen other of my videos, you probably remember my favorite client, Sydney Magruder. And sometimes she will start whining when I'm trying to work from home. And so if that's my problem, it makes sense that we would focus on the problems. And thinking about our mental health system, right, it's geared towards more of a medical model, pathology. There's a lot more articles about anxiety than there are about serenity. And so it makes sense. This is natural to focus on the problem. But I'm going to use this example to help us look more at the cure rather than the disease. So the problem is the whining. The solutions then might be to make sure that she gets a nice long walk in the morning before I'm really having more meetings or quiet working time, having plenty of toys out in the house for her to play with, or working from my couch where she's allowed up with me to cuddle if I'm, just kind of working on stuff on my own. These are all solutions, making sure she's warm and bundled up because she gets cold sometimes. So let's compare that, say, to cognitive therapy, where the problem might be I'm annoyed that my dog is whining at me, and it might be examining a cognitive distortion of, oh, well, not all or nothing thinking, right? Like she doesn't always whine, it's only sometimes, and kind of restructuring those negative thoughts. That's kind of comparing. That's a totally different modality. Here we're really looking more at solutions. The metaphor I mentioned earlier is this. You want to get in the water with your clients. So if I imagine myself as a swimming coach in my therapy role, I need to know what it's like to swim in general, but I also need to know what it's like to swim in these specific conditions. How cold is the water? How strong are the currents and the waves? How close or distant are those sharks coming in the water, right? You need to fully understand their circumstances before you can coach them on the most effective way forward. And so kind of having this understanding of like, you need to get in the water and listen and fully understand the situation before you're going to have any accuracy or authority in being able to make any suggestions about solutions. Marcia Linehan, the person who created dialectical behavior therapy, has an analogy that I really like that I think is very related to solution-focused therapy, which is if you imagine that your client is in the corner of a burning room in a burning building, you might tell them to run through a flaming door or out the window to safety, and they're not really going to like trust you. Like it's kind of scary. They don't really want to do that, even though that's the only way forward. And you have to have that trust to say, I can see the way, like I know what to do. That being said, the things that I just described are a lot more paternalistic. It's more, I'm telling you what to do. Like I'm the all-knowing, wise, omniscient one who is going to dispense solutions for you. And that's not realistic either. We want to instead collaborate with our clients. We don't want to be too directive, and we want to elicit their own ideas for change and solutions. And I'll share more about how to do this in some of the tools that I'll get to in a moment. In a more crisis intervention situation, I might be a little bit more directive, but in most cases, I'm not going to be making a suggestion of here's my advice and you have to follow X, Y, Z. We're going to work together to come up with solutions and plans. All right, so all that to understand what solution focus means. Now to the brief part. Of course, implies that we're getting things solved quickly. It's strategic. And there's a famous quote here, DeShazer, who's one of the people who's often associated with solution focused therapy, along with Milton Erickson and a few others. They say, that the number of sessions should be as long as it takes and not one session more. Some sources will say it's time limited and give you a certain number of sessions, but others don't. So this is a little bit up for debate. But I often say to my clients that if you are totally dependent on me as your therapist forever, I'm not doing my job properly. That doesn't mean you have to be cured next week, right? That doesn't mean that you won't ever need support, either from a professional or from family and friends, but the idea is to help you to gain those coping skills and social support network and so forth that are going to help you deal with those waves of life that come on and swim on your own. And again, not in any way trying to stigmatize ongoing or long-term therapy use. If that is a helpful complement to a life that you're doing well in, great. But if that is just the only thing that's keeping you hanging on by a thread and that lasts for years and years, it might not be the most effective therapy. And strategies can also be individual, these kind of brief approaches, or they can be more system-oriented, like a family. So we kind of think about, does the client need to change or does their environment need to change, which aligns with our social work person and environment perspective. I'm going to emphasize here again that in our quest for solutions and improvements, it takes some finesse to really show that you care and have patience and that you're not trying to rush to fix things. They need to feel like you really get it. And this is particularly important for clients who might be high achieving or people pleasing by nature. Sometimes they can feel pressure to perform even for their therapist. I had one client that I really just got a sense, and maybe it was a little bit of transference going on, but I just really had the sense that he wanted to make me proud. And I had to tell him once, this is not about, this whole therapy is about you feeling better, not about making me happy. I'm glad and encouraged to see progress. I, of course, want to see you improving because I'm on your side and on your team. But if you've had a bad week, that's not anything to be ashamed of to share with me. That doesn't mean that you're not progressing fast enough or I'm going to be disappointed. So that's something to maybe keep in mind too, would be my tip. Here's what a session might look like in a solution-focused brief therapy format. If you practice CBT like I do, this is going to look quite familiar. And it usually starts with a brief check-in, kind of seeing, how have you been since the last session? Did anything major happen? This is not, okay, how's it going? And they launch into, talking about everything, and that takes up the whole session. It should be a little bit briefer, but of course it's going to vary. If something major happened since the last time you saw them, that might be a cause for attention. But kind of getting a check-in, you could use a 0 to 10 rating scale here if you do that to measure progress, or PHQ-9 or some other tool if you use regularly, or just kind of, how's your mood, or have you been sleeping, or whatever it is that they've been working on. Then we want to quickly get to the accountability of how did the homework go. So often in solution-focused therapy, we work together to identify homework that they can do to practice. There's 168 hours in a week, and they're only with me for maybe one of them. So incorporating the strategies that we talk about in here, out there, is really where the progress happens. And in order to help them do that consistently, you want to remember what it was they were supposed to work on and ask them how it went. I try to be non-judgmental, right? I want to hold them accountable, but I'm also not going to yell at them if they didn't do it. But just they know that you're going to ask. And I even had a client once say that one of the most valuable parts of therapy was just that accountability and knowing that I would be asking whether they exercised and whether they, did X, Y, and Z that we talked about. Then we'll figure out how we're going to use our time today. What are we going to focus on? What do you want to talk about? And so forth, kind of figuring out goals and agenda. Then you do the dang thing, and that's where the bulk of the therapy really is. And as it starts to wrap up, then you're going to agree on homework. Hopefully that comes organically out of the session, from what you've been talking about in this section here. And summarize what you heard them talk about. Of course, you're going to do some reflecting in the therapy itself, but just more of a big summary of, okay, like this is what we did, here's what we settled on. And then you can get feedback on the session as well. What did you think of our time together? What was most helpful? This is particularly needed if you're not really sure what was most helpful or what really got through to them, if anything. If it organically comes up that you stumble upon an insight or something and it's like, boom, big light bulb moment for them, or they really love, some psychoeducation that you did, like it might be kind of obvious what was most helpful. But if it's not, you can, ask about that, just kind of check in. So in this section where you do the therapy, here are some specific things that you might do. And you can pick out what's most helpful for each individual client. They come to us to feel better, not to be dazzled by our therapeutic prowess. So use what works for them, even if it's an entirely different tool or modality altogether. One of the things that you should keep in mind here is collaborative problem solving. This is the spirit of solution-focused brief therapy. We want to instill hope, but also don't act like it's so easiest and obvious, right? If we kind of come in and say like, oh, well, clearly, if you're not sleeping well, it's because you're watching TV too late at night or you're drinking coffee too late. Like it might seem obvious to us, but if we do it in a condescending way, one, it's not going to be very well received and they're probably going to be very defensive, but also we want to instill that empowerment and hope. So as much as you can make that problem solving happen together, that is going to give them that self-efficacy and also make them much more likely to actually try implementing those solutions in the future. Scaling is a classic technique in solution-focused therapy. This could be an assessment tool, but it can also be the fodder for solutions themselves. You'll base it on what the presenting problem is, whether it be like a panic disorder, substance use, etc. You want to make sure to explain what the 1 and 10 mean. So sometimes 1 is good, meaning the absence of a problem, or sometimes 1 is bad, meaning you're in a terrible spot. So making sure that you actually explain that. That's why I chose the image of this scale here, because intuitively I think 10 is good and 0 is bad, but on this scale it's reversed. So doing something that is intuitive to you and your clients, and again, explaining what a 1 is. So 1 being the worst panic attack you've ever had, 10 being total tranquility and serenity. If I'm working with a client for multiple sessions, I might even have them create their own rating scale. So if we look at like a panic disorder as an example, I might have them tell me, okay, what's a 1, what's a 3, what's a 7, what's a 10? And that way, they can use metaphors or comparisons that are meaningful to them. So a 10 in terms of like serenity might be a Buddhist monk, or how they feel after they get a massage, or a day at the beach, right? That's going to look different to different clients. And so that can make it more personalized. The benefits of scaling is that you can kind of show, you can point out those could be worse exceptions. So as long as you don't pick 0, it gives me the opportunity to ask why it's higher than it could be. So for example, say it's a 0 to 10 scale, 10 is good, 0 is bad, and they say they're at a 3. It's natural to say, oh no, why is it a 3? But in solution focused, and actually in motivational interviewing, which is where I learned this technique, so I'm kind of crossing over here, but it's okay. You can instead say, well, why a 3 and not a 1? And it forces them to talk about what motivational interviewing calls change talk, or solution focused would call solution focused talk. It can be handy also to track progress over times and see patterns and show that there's variability in both directions. Things get better and worse, and it can show that progress isn't always linear, and that's okay. That's kind of how life is. But it can help disrupt some of that black and white thinking, and tracking progress. And so those are, I think, some of the things I would say are most helpful. And then some of the risks here, again, there can be some lack of clarity in what the scale is really measuring. There could be cultural or personal differences. You know, a 5 to me might be a lot different than what a 5 looks to you like in terms of, say, depression. And you also want to be aware of inappropriate timing. So, for example, you wouldn't want to interrupt someone mid-meltdown because that can seem really insensitive, right? If someone's like bawling and just having a really hard time, like, you need to ground them, center them, listen, right? So if someone's like, oh, like my mom just died, like, you're not going to be like, hold on a second, on a scale from 0 to 10, like, how distressed are you? And you're like, are you kidding me? So thinking about when is the right moment to use something like this. A classic question that you can ask is, what are your hopes for this therapy? That could be initially in the assessment phase, or it could even be every individual session. What's your hope for this day? If you know anything about solution-focused therapy, you know about the miracle question. And it goes something like this. Suppose that one night there's a miracle, and while you're sleeping, the problem that brought you to therapy is solved. When you awoke in the morning, how would you know that this had happened? What would be different, and what would others notice? That's the miracle question. I think that there also may be multiple solutions or steps to a solution. So say the problem is you got to get rid of your old, saggy, disintegrating couch. The overarching solution is to, say, get your friends to help move it. But there's several steps to actually making that happen, and helping those little victories happen can be really important, especially with someone with avolition or like a lack of motivation. So first you got to call Jill, and then you got to ask your, neighbor Jack, and then you got to order pizza to thank them for helping you with moving. And if you only do one part, it won't work. So you have to build on those successes and realize that there might be several things you need to do. And if you say, well, I only called one person, they said, no, this isn't working, that's not the whole story of the solution. And there might be some trial and error. So maybe you call up your buddy Fred, and his calendar is suddenly very busy now that he knows you want to borrow his pickup truck. That's okay. You look at other options to get you to that solution. Pop quiz here. What do an elephant, dominoes, and a ladder all have in common? They are all common metaphors used in solution-focused therapy for essentially doing one step at a time. This is particularly helpful with unmotivated clients to kind of help you start somewhere. So the elephant, classic question, how do you eat an elephant? One bite at a time. Ladder being taking steps up the ladder. If you want to reach the top step, you can't just do that in one gigantic step. You got to have multiple things, and you won't be at the top yet, but you'll be getting towards it. And then particularly with folks who have some sense of inertia, I see this a lot with depression, thinking of it as like a domino effect of, it's going to be really hard to get yourself in the gym on day one, but once you start building a habit, it's going to be much easier to continue doing this down the line. Another question that you might ask in solution focused, another tool here, is the post-mortem. It's sort of similar to the miracle question, but it says, suppose 6 months from now, you look back and say to yourself, man, if I had only done fill in the blank. Starting 6 months ago, things would already be so much better. What would that such and such be? So maybe it's being more grateful for the things that my spouse does in our relationship, or being more open and communicative about problems I'm experiencing at work, telling my boss like how I'm feeling. Right? What are those things that you can do now that might not make you feel better tomorrow, but in 6 months is really going to help with your solution finding? Strengths and resources is so key and solution focused. What is already in place that will contribute to these hopes becoming a reality? Right? Social workers love the strengths perspective, and we are experts at resource finding, so this is perfect for us. So looking at, what can you leverage? What good things are going on? And how can we use those to our advantage? When you have a client proposing or explaining that they have tried some ineffective approaches, trying to find solutions, but it's just not working, like, for example, someone with social anxiety isolating themselves away because they're very nervous, and that just makes them more socially anxious. I'll sometimes, depending on my rapport and the sense of humor of the client I have, kind of do a lighthearted, well, how's that working out for you? Kind of drawing attention to the fact that this is not working. And so doing more of that thing that's not working also might not work. So how about let's try something different? A great way to actually get someone to those solutions is finding exceptions. I love this one. So, for example, say someone is feeling very anxious. I might say, has there been a time in your life where you did not feel this way? And they'll say, oh yeah, whatever, last year when I was in college or whatever. I'll say, okay, what was different then? What did you do differently? What were different about your circumstances? And is there any of that we can recreate or come back to? Maybe you ate healthier. Maybe you had a stronger support network. Maybe you worked more hours and you had more purpose. Maybe you worked more hours and you were more anxious, right? So just what was different? And we want to kind of stay in line with our role as mental health professionals while still recognizing whole body wellness. So it'd be okay for me to share data and statistics about how mental health improvements are correlated to regular aerobic exercise without me also saying, and I'm going to be your personal trainer and these are the things you have to do, right? Same with nutrition. It doesn't take a rocket scientist to say that eating healthy is going to be better for you in many different ways without me having to make a meal plan for them. In finding exceptions, this can bleed pretty easily into behavioral activation, which I like from a CBT perspective. And that's the idea of doing activities that are pleasurable and enjoyable and make you feel good. So at the very least, giving you something to look forward to, getting your nails done or going on a trip or going out with your friends, on a weekend. And so that's a nice way that you can kind of integrate two modalities together. And good old-fashioned brainstorming, right? Identifying what's the problem, what are some possible solutions. Sometimes, if you have a whiteboard in your office, this can be really nice to actually physically jot things down or in a notebook, reviewing the pros and cons of each choice, having them decide, and then you try it and you evaluate if it worked. You are kind of co-experimenters in this and going to try different things. And if it doesn't work, that's okay. We'll try the next one until something does. You also really want to consider in terms of who's appropriate for solution-focused brief therapy. What stage of change are they in? You might be familiar with, the pre-contemplation, contemplation, and so forth. It makes me think of this old, 90s country song called I Just Want to Be Mad. And I have the lyrics here. I'm sorry, I will not sing it for you. But the point of the song is basically that I'm just not ready to make up. I want to be mad. I'll forgive you. But right now, I'm not ready to laugh and smile. I just want to be pissed off. And that's how some of our clients are, right? So we need to meet them where they are, and we can, try to move them towards solutions slowly, but if we push too fast, that's probably not going to go well. I normally never do this, but my dog was whining just like she did in the example. So I'm going with a solution, which is to hold her in my lap while I finish this video, because I'm a solution-focused therapist. So what if there is no solution? I always tell clients that there's really two different ways of addressing any given issue. You can change it, or you can learn to cope with it. So in the case of, say, like a phobia or an eating disorder, that is something that you can actively take steps, whether that be some exposure therapy or different things to actually change your behaviors, to change the issue. Whereas there's some things that you can't change, like bereavement. A loved one passed away, you can't bring them back, or a trauma happened, and you can heal and cope and move on and hopefully have some post-traumatic growth. So sometimes people get so focused on the change, and if there's no solution to change it, they say, well, there are no solutions. Well, there's also coping solutions. So keeping that in mind can be really helpful as well. My final question for you is to kind of have some food for thought here and think about, does solution-focused brief therapy skip any necessary root findings? Is this avoiding the problem? So if you practice this in your work, I would really encourage you to consider, how do you strike that right balance between, again, making clients feel heard, helping you to fully understand the issue, and gain insight about maybe patterns of behavior or things like that, but also moving towards, away from those roots, get out of the dirt. You can find the roots, but don't stay there. Let's get to the growth part and look at these solutions. So here are my references, and if this was helpful, I have videos about several other therapeutic modalities that you might want to check out in my clinical social work playlist. Thanks for watching.